Medurstand, Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today I am going to talk about the role of insulin in the management of type 2 diabetes. Now, those of you who have not watched my earlier videos, I have already released two videos on management of type 2 diabetes, part 1 and part 2. In part 1, we discussed the basic principles of management and we emphasize the importance of lifestyle changes, and we also covered some of the traditional oral agents. In part 2, we discussed some newer oral agents and some injectable other than insulin. In this lecture, I'm going to focus on insulin. So I think those of you who have not attended the earlier lecture, it is very strongly recommended that you find time to watch those videos also, so that you can have overall idea about the management of diabetes type 2. The outline of this presentation is, first of all, of course, the aim is to get our glycemic goals achieved, and we implement that plan. We usually start with oral agents, we make them double, then triple, and then ultimately almost all type 2 diabetic patients, if they live long enough, if they do not die of diabetic complications or if they do not die of some unrelated causes, ultimately majority would need insulin, because we understand that in type 2 diabetes, although at the time of presentation 50% or more cells are intact, but with time, no matter what you do, beta cells are damaged further. So far, we do not have any effective therapy to prevent beta cell loss. So beta cell loss will continue, and most patients will need insulin ultimately. And choosing a right regimen is very important, because we have number of insulins available and we have number of regimens, and I will try to explain which regimen will suit which patient. And of course, at the end, I will present the summary of this lecture. Let me first make a confession on behalf of medical profession. Restoration of glycemia to exact physiological state without the risk of hypoglycemia and weight gain is not possible. I wish we could normalize glucose level in all diabetic patients without giving them the risk of hypoglycemia, but so far it is not possible. So that is why even the best control is a compromise. We need to use currently available tools to get it to as close to the normoglycemia as possible with acceptable risk of hypoglycemia. I think anybody who is having good control will probably have occasional hypoglycemias. So it is not possible to get to the goal without having even the slightest risk of hypoglycemia. But if hypoglycemias are too frequent, then of course the treatment plan has to be revised. Now we know that hyperglycemia correlates with cardiovascular complications. HbA1c is a surrogate marker of hyperglycemia, and various studies, particularly in UKPDS, it was demonstrated that as your HbA1c goes up, your chances of developing myocardial infarction are increased. And similarly, when your HbA1c is lowered down by therapies, your risk is reduced. Of course, the risk is not completely eliminated, and that is why we want to add some additional therapies. Of course, our main focus is glycemic control, but we do use many therapies to bring down the risk of myocardial infarction. My next lecture is going to focus on that, what additional therapies we will use to lower down the risk of macrovascular complications in type 2 diabetes. Now, both fasting plasma glucose and postprandial glucose both are important. Now we know that when somebody's A1C is very high, like more than 10.2, major contributor, like 70% contribution is from the fasting plasma glucose, and 30% contribution to HbA1c is from the postprandial glucose. So at this stage, if we focus on fasting glucose, that will do the job at least to a certain extent. But as we get closer to the goal, like this one is 7.3% or less, our goal is 7%. Now you please appreciate that as we get closer to the goal and the postprandial glucose, the glucose after the meal becomes more and more contributor to HbA1c. So if we want to get to the goal, of course, we need to focus on both fasting as well as postprandial glucose. That is what we always do. But just to make sure that some simpler therapies, they can control fasting glucose easily, but we need some special efforts to bring down this postprandial glucose if we want to achieve good glycemic control and if we want to achieve our goal of 7% or less. Now, this is a triad of glycemic control, fasting plasma glucose, and patient is asked to monitor fasting glucose. Those who are on insulin, they have to do it at least once a day in the morning every day, and then they could do postprandial also. Postprandial is important. We always control fasting first. That is the usual strategy. It is also called fix fasting first. So when we start treating patient with type 2 diabetes with insulin, first we focus on fasting plasma glucose, and then we give additional treatments or we make further adjustment in the dosage of short acting or rapid acting insulins to fix postprandial glucose. Now it is important to mention here that postprandial glucose correlates with cardiovascular complication more closely than fasting. Now this is very important because 75 to 80% of the morbidity and mortality of type 2 diabetes is related to cardiovascular disease. So I think we would definitely like to focus on postprandial glucose to reduce cardiovascular disease. Now both these are collectively represented by hemoglobin A1C, and this is convenient because it can be done at the point of care or just before consultation. Patient can bring the report and it's very convenient. It gives you the average value. But there are some caveats. Now this is, for example, somebody's glucose profile, postprandial and fasting, it goes up and down. And this is another person's glucose profile. It also goes up and down. And if you calculate the average would be the same. So these two individuals may show the same HbA1c, but the actual real life situation is different. This person is close to the normal physical range most of the time, and this one has a lot of excursions, postprandial hyperglycemia, then maybe little hypoglycemia. So I think this one is better than this one, this profile, although both would have the same HbA1c. So I think that is why we do rely on HbA1c very much, but we also give a lot of importance to home plasma glucose monitoring, and fasting glucose is important and postprandial glucose are also important. So we do all three to have the best idea where we stand and what kind of glycemic control patient is having. Now, ideal is perhaps continuous glucose monitoring. That is a wearable device, but is very expensive and maintenance cost is also fairly high. And this is very useful in type 1 diabetes. In type 2, mostly it is not used. Mostly it is an experimental tool still. But there are some simpler variations of CGM. I think they are useful, especially in those type 2 diabetic patients who have marked fluctuation in their glucose level. Aim of the treatment the glycemic aim is to bring their HbA1c to less than 7, ideally less than 6.5 or even less than 6 in younger patient. Various societies, they have given different goals. 7 is typically given by American Diabetes Association and European Association for Study of Diabetes. 6.5 is given by IDF and also by American College of Clinical Endocrinologists. But all societies, they indicate that you should get to less than 7 if possible without the side effects, without the effect of the medication. And fasting plasma glucose, ideally between 100 and 110. The range is 80 to 130. This is again ADA. Other societies give 70 to 120, but I think you should follow just one, 80 to 130. That means anybody's fasting sugar falling in this range would be considered acceptable, although somebody who is very close to 80 is likely to go into hypos, and somebody who is close to 130 is likely to develop hypers and complications. So I think best is somewhere in the middle, like 110 or 105, like that. And postprandial glucose should be less than 180. And other societies, they say it should be less than 160. Please note down, this is not exactly achievable in everyone, because postprandial, number one, let me make a point that the time of 2 hours should be counted when we start the meal. The time which we take for the meal should also be included in this 2 hours. And number two, it depends on what kind of meal you took before this test, and also the composition, and of course the size. Now, and different patients, they have different sizes of meal. Like breakfast is typically smaller in our culture. In Western society, breakfast is usually big, and we then take lunch also, we take the dinner also. So depending upon the meal size, you should expect something between 140 and 180. And at the same time, the secondary aim is that we should try to achieve these goals with minimum hypoglycemias and minimum weight gain or no weight gain, or ideally weight loss, because most type 2 diabetic patients are actually overweight, and it should be as convenient and doable regimen as possible. Very important, because patient has so many other things to do. I think if the treatment plan is simple, doable, convenient, that will translate into better adherence and better results. Now, this slide was shown earlier also. Typically, at the time of diagnosis, we talk about lifestyle changes, and we immediately implement them. And these days, especially if the HbA1c is at the time of diagnosis is 7.5 or above, we add oral agents, usually metformin. Then we add other oral agents, and then especially in those patients who are at high risk of atherosclerotic cardiovascular disease, we consider GLP receptor agonists. And please note down, according to the new recommendation, and for those patients who are having atherosclerotic cardiovascular disease, or those who are at the risk of developing atherosclerotic cardiovascular disease, GLP receptor agonists should be considered before insulin. And of course, insulin is the ultimate thing. Those who do not respond to any combination of these drugs, they ultimately need insulin. Some questions about insulin. I think these are of some practical importance. You might not find these questions very academic, but I think they are very important practically. So this is kind of interaction, some kind of virtual interaction I'm going to have with you. After displaying a question, I will give you a second to ponder and come up with the answer. When should we talk about insulin? I think when we do first time briefing at the time of diagnosis, We talk about lifestyle changes, we talk about the importance of glucose control, we talk about oral agent, and we also talk about the possible use of insulin sometime down the line. So I think that is the best time to talk about insulin as one of the treatment options. If you have not done it that time, when you see that orals are heading toward failures, not when they actually fail, when you can see that we have to increase oral agents and we are going to the almost maximum dosage and patient's A1C is not exactly at goal, that is the time we start talking about insulin. I tell you, my experience tells me, especially in our culture, patient usually will not accept your advice of insulin when you present it for the first time. So I think when it is actually needed, it is best you start talking about insulin one or two visits before that, so that patient prepares his mind, and whenever insulin is ultimately offered, he accepts it readily because he was already actually anticipating that. How should we portray insulin? Uh, a treatment of last resort, that is the perception of most patients. I don't know why they consider if it is the last resort, they are perhaps coming towards the end of their life. This misconception should be relieved, and this misconception should be cleared. This should be explained that insulin is a friend that stands with you when others have left. So that kind of example. So there is a situation that orals or non-insulin injectables are not working and insulin is still possible. So I think we should uh, give this example to the patient, and I think the more chances that patient will accept insulin. What is the best way to start insulin? Now there are two possibilities. Just advise, just prescribe and let him figure out how to inject, or demonstrate it yourself or through your diabetes educator. What do you think? Of course, if patient is familiar with insulin, is one of his family members using, he could be just prescribed. Or these days we have very good resource that is YouTube. I think you can ask a patient to watch a video on the YouTube how to inject. But I think ideally, if you have time, demonstrate the proper use. I always do it, although I have time constraints, but I always try to demonstrate it, the proper use. And I see two advantages. Number one, I feel satisfied that I have demonstrated the proper use, proper way of administration of insulin. The other advantage, the hidden advantage, is that once we have agreed on this plan, that plan has been implemented also. Now, if you just prescribe insulin, it is quite possible that when patient goes home, he changes his mind. Somebody in the family tells him that you should not take insulin. So I think I always find it very, very rewarding doing this demonstration of insulin use myself. Does starting insulin mean the glucose will be controlled immediately? Because you have been making a case for insulin and patient was reluctant, and now that insulin has been started, patient would expect that now sugar will be controlled immediately. Is that right? Not necessarily so. You will have to choose the right regimen because every patient has got unique needs, and you have to choose the right regimen and you have to escalate to the right dose. Now this has to be explained to the patient. You need to tell him that this is the new medication, and just like we started with oral agents and then we increase the dosage, similarly we will have to up titrate the dosage of insulin till we get to the goal. So I guess this was useful, this part, some questions about insulin. Advantages and disadvantages. We understand that everything in this world has a downside, but insulin has got a very big upper side. So I think first we talk about the advantages. Always effective. Since insulin does not depend on any other system, it has got direct effect on glucose, so it would be effective whether you use the start of diabetes, whether you use when patient is already diabetic for the last 25 years. So it is always effective, although you would need different dosage for different persons. Sometimes 10 units may be enough. Sometimes you might have to go to maybe 100 or even more. So that is a different thing, but there will be a dose which will be able to control glucose to the desired level. And there is no ceiling. You can start with 10, 12 units and you could go to any level. Like you could actually go to 500 international units, although nobody would like to inject that much, but theoretically at least there is no ceiling. The disadvantages, there is real risk of hypoglycemia, and we have now new insulins where the risk of hypoglycemia is minimized. There is definitely risk of the weight gain because insulin is an anabolic hormone. Logistics, insulin has to be stored in a refrigerator, and very sadly in our country everyone does not have access to the refrigerator. And stigma of being on insulin, and this is very important in our society. Now imagine if there's a young girl who isn't yet married. Now if she has to inject insulin, and I think the parents would assume that this girl would not be able to marry because nobody will accept a woman who is on insulin. This is very sad. This is actually that we need to do something about it. We need to improve the health education, but this is actually true in our society. Needle phobias. Some people are very scared of phobias, and I think very importantly, some people, they just have attitude issue. They have just heard that insulin is not good. If you ask them why not, they have no argument, but they just no insulin, but they simply say no to insulin. I think we need to discuss with the patients, and I have strong conviction that if you talk to them at length, mostly I think you will be able to sell your point, and patient will be able to accept your idea of insulin. Now, history of insulin development. It was discovered in 1921. 1921. This is now, these days when this lecture is recorded, we have 2021. So almost a century ago. And initially the pancreatic extract was used. There's a famous story. I will not go to the detail because time will not allow. Then those insulins were purified, and they were taken from pork and beef. Pork insulin was much closer to human insulin. It differs by only one amino acid. Beef insulin differs from human insulin by 3 amino acids. But because of the religious or cultural reason, in our country we never had pork insulin, but we did have beef insulin. It's not available now, but it used to be insulin available about 20 years ago. Then we have modified insulin, NPH, PZI, and Lente, because the purified regular insulin has got short duration of action. That means it will have to be injected 3 times a day. Then some scientists made it long acting by modifying, by attaching protamine, other stuff, and these are the insulin which are converted from pork, beef into these NPH, PZI, and Lente, moderately long acting, intermediate acting medication. Then came the era of recombinant human insulin. Now this is human insulin, but not derived from human beings. Of course, nobody would like to donate one's pancreas, and it is like derived from E. coli or yeast cell, mostly I think E. coli, the gene for insulin is taken from humans and that is inserted into E. coli, and then E. coli they start producing insulin. So since E. coli they don't need insulin, so we extract it and then purify it. So that is dispensed in the form of regular insulin, and that can also be modified to NPH. So this is recombinant human insulins. When recombinant human insulin came, we thought that we have conquered type 2 diabetes, but then we realized that there are problems with the human insulins also. Then came the era of insulin analogues. These are rapid acting insulins. Now, rapid acting insulins mean aspart, lispro, glulicine. These are three modified rapid acting insulins, because scientists they made little change, just a replacement of one amino acid with another one. They change the characteristics of the insulin, the physical properties of the insulin. Human insulin, when injected subcutaneously, it makes hexamers. That means 6 molecules of insulin, they bind with each other and then they slowly dissociate and then they are absorbed, and this takes about half an hour. And these insulins, they do not make hexamers, they remain in monomers and they are absorbed quickly. So they are very useful prandial insulin. If you want to cover the prandial phase, the phase following a meal, I think these rapid acting are very useful. All three have almost the same profile. Then we have long acting analogues. Human insulin is modified by again either substituting some amino acid with another one, or attaching a fatty acid chain with that one, or some other manipulation. So to aim is to then this time the insulin becomes truly long acting, because instead of hexamer, polyhexamers are made. So very slowly they detach and then is absorbed. So giving one injection per day gives you 24-hour coverage. So there has been a lot of improvement in the human insulin to make them ultra fast acting and ultra long acting. Then we have insulin pumps, and there is, I think, in oral insulins. There is a long story. Initially, oral insulin were developed and didn't succeed. They're still in the development phase. Then there were inhaled insulin. They have been abandoned. Again, it's available, but I think currently our most of the treatment focuses on these two. So my next few slides will be focusing on these two groups: human insulins and analogs, insulin analogs. Now this is the list of insulins. Now of course it's not easy, it's not possible to go through this table, but I'm going to help you by focusing one component at a time. Let's first talk about the regular insulin. Regular insulin, there are two examples: regular human insulin, actrapid and Humulin. I'm using the trade names because you will have better comprehension. It's not to promote any company or any particular brand, but just to help you understand these better. Actrapid and Humulin are, the onset of action is 30 minutes, duration of action is 6 hours, and frequency of administration is thrice. And they are recombinant human insulins. These are two examples. Then we have intermediate acting, again derived from human insulin, NPH. The onset is in 2 hours, duration of action is 16 hours. Note down, this is not 24 hours. That is why it is intermediate acting. It has to be injected once or twice, although ideally it should be injected twice, but sometimes we inject once, and they are modified human and intermediate acting. And then we talk about the rapid acting. There is some confusion. This is regular, and this is called, actually also called short acting. You could call regular short acting, and this is analog rapid acting, because This takes about 30 minutes and this takes only 10 minutes because this one does not make hexamers. So we have three examples: aspart, lispro and glulysin, and their duration of action is 4 hours. Now what do you think? This 4 hours as compared to this 6 hours, is this advantage or disadvantage? Many would think that this is a disadvantage, but actually this is an advantage. I'll explain to you later how. This early onset as compared to regular insulin is an advantage because you will not have wait for half an hour before you can take your meal. You can take insulin and within 10 minutes you can take your meal. And this 4 hours as compared to 6 hours is advantageous because once you have eaten for the last 4 hours, the risk of hypoglycemia will be minimized with the rapid acting because there will be no much insulin in your body at this time when you have not taken your next meals. With regular insulin, before the next meal, patient is likely to go into hypos. So this is also injected thrice a day. These are analogs, rapid onset and short duration. They are best prandial insulin. Prandial insulins are the insulin which are used to cover the fasting, the post meal phase. Then we have long acting, and there are three examples: Detimer, Glargine and Degludec. These are all insulin analogs. The onset of action is from 2 to 4 hours. Duration of action is from 20 to 40 hours. Now look at this Degludec. It works for 40 hours. And they're all given once a day. They are analog and long acting and peakless. This is very important because it is the peak of insulin which correspond with hypoglycemia. So these insulins, the newer insulins, are peakless. Glargine comes in two forms. One is Glargine U100 and the other one is Glargine U300. Although it is the same Glargine, but it is concentrated, and the profile of Glargine 300 is almost similar to the profile of Degludec. So they are very, very long acting and almost completely without a peak. Then we have mixed insulins. Mixed insulins are of two types. One is free mixed. That means we have insulin N is for NPH, and we have insulin R, and immediately before injecting we can mix them as prescribed by the physician. Like we could take 70 units of the 20 units of this, 10 of this, 10 of this, 10 of this, like anything. I think we make a lot of improvisation in insulin. So these two can be taken from two different vials and mixed immediately before injection. Or there is pre-mixed. Pre-mixed means that in one vial you have both the insulins, short acting as well as intermediate acting, and in a certain ratio. Now the most popular ratio is 70-30. 70 is N and 30 is R. In this fixed ratio, the onset of action is like not actually 4 hours. This should be 30 minutes. I'm sorry for the mistyping because it has got a short acting component. The short acting component will start working in 30 minutes and the long acting will start working later. So actually the onset of action will be 30 minutes. And if you're using pre-mixed analogs, then it will be 10 minutes. So 16 hours and once analog long acting. I'm not sure what is here, but yes, this is analog and long acting combination. So I hope this was not too much for you, but this was important to understand. If you did not understand any component, you could always pause the video and you could rewind it and then listen to this part again. This is the profile of different insulins in graphical form. Now I will emphasize only on two things: human versus analogs. First, short acting versus rapid acting. Short acting are human insulins, and rapid acting are insulin analogues, short acting, rapid acting insulin analog. Now this graph, this one, this yellow, I am little color blind. I'm not sure if you would call it yellow or orange, but this one, I think yellow. This one is short acting, regular human insulin. Note down that if it is injected here, it will take 30 minutes before the action starts, and then effect lasts for up to 6 hours. Up to this level, it tapers off further slowly, and it could take up to 10 hours before the effect is finished. Compared to rapid acting like insulin aspart or lispro, this green or black, I think black, it's a dark green or black, this curve is this one, black curve is, it starts working faster and the duration of action is shorter. So that means if patient takes meal here, immediately before meal he can inject this insulin and there will be rapid action. So hyperglycemia during meal will be less chances. There will be less chances of hyperglycemia during or immediately after meal, and also less chances of hypoglycemia 3 hours later. So this is the comparison of short acting and rapid acting. I think I have tried to make a point that rapid acting are technically better because they start working faster and their duration of action is shorter, so hypoglycemias before the next meal are less likely. Now let's compare NPH versus long acting. This one is NPH. Two things. Number one, it has got a peak. When patient is passing through this part, the peak part, patient may develop hypoglycemia, and this may be actually when patient is asleep, so that could be a problem. And the second thing is that the maximum duration is just 16 hours, 14 hours to 16 hours. It does not have 24-hour coverage. So if it is given once a day, at this time patient will develop hyperglycemia. So this is the comparison of NPH versus long acting. Again, I hope I have made a point that technically speaking, these long acting insulins, which are insulin glargine, datamar or degludec, they are technically better because they have 24-hour action. Now you might wonder that with this part is not covered. No, it is actually. When this medicine, this works for beyond 24 hours, and by the time you inject insulin in the morning, the effect of previous days of insulin is still there. So this part is also covered. So you actually have flat curve with these insulins. We have discussed various insulins and we have discussed indications of insulin and various types, their profiles. And I think in the next part of this lecture, which is part 2 about the usage of insulin in type 2 diabetes, I will explain in more detail the actual application of these insulins in a particular patient. And I will also explain how to make various combinations, how to use various insulin in various scenarios, and how to adjust their dosage to get their HbA1c to the normal level, to the level less than 7, and keep it there. So I'm really looking forward to see you in the next part of this lecture. Without that, actually, this module will not be complete. So I strongly recommend that you watch the second part on insulin also. Thank you.